The next chapter is a discussion on what actually controls the arterioles. So it's a vascular control mechanism. Ultimately, what you're talking about is what is taking place at the vascular smooth muscle of the arterioles. Okay? So whatever mechanism is available to control the adjustment of how tight the vascular smooth muscle is ultimately what you're talking about. Okay? The blood vessels, which specifically we're talking about the arterioles, are really where blood flow is regulated to separate organ systems, okay, which I've said before. Okay? The actual distribution of blood volume and the actual cardiac filling, on the other hand, is the veins. So that is really important for, in other words, preload, coming back to the heart. Okay? Now, smooth muscle is very different than skeletal muscle and cardiac muscle. Okay? It's architecturally different. It has different oxygen utilization needs in comparison to other blood vessels. The good thing about smooth muscle is that it can provide prolonged contraction for prolonged periods of time, okay? With the least amount of oxygen utilization in comparison to skeletal muscle or cardiac muscle. So it's a very efficient muscle for prolonged contraction, okay? The other thing, too, is that it relaxes a little bit more slowly than skeletal muscle or cardiac muscle, but it still does it pretty quick. I mean, it's not like it's super slow. It's not a slug. Okay? It is slow, but not super slow. Okay? If you have somebody who suffers a significant sympathetic loss that's rapid, the cardiovascular system will collapse on you very quickly. Okay? You're talking about seconds. So it can happen pretty quick. Okay? What you're looking at is a smooth muscle is also important in the sense that it's like, in the gear ratio wise, if you had to describe it, it would be like your reverse. It doesn't go very fast, but if you comparison to the drive, it actually can pull more. You can do a lot of work. Okay? If you've ever been stuck in mud or in snow, what gets you out of the snow or mud is actually not putting not the car in drive in first or second, is to put the car in reverse. If you don't know that trick, it's a great trick. And since if you're depending on which kind of car you have somebody sit in the back or the hood or on your trunk, and then it digs the wheels in and you get yourself out. Okay? Smooth muscle is like that. It can give you a prolonged contraction with lots of power for prolonged periods of time, but it doesn't do it very fast. Okay? The resting membrane potential of the smooth muscle is actually very low. It's between minus 45 to minus 65. So it's very similar to pacemaker cells, but it's not similar in any way to cardiac muscle cells and skeletal muscle cells, okay, which are working usually at minus 85. Okay? And the other thing that's important to know is that if you have a lower resting membrane potential, that means your ATP utilization is down, it's less, okay, which is true. Okay? The ATP utilization is actually lower than almost all other kinds of muscle in your body. Okay? Your potassium is still important for maintaining your resting membrane potential, just like anything else. Now, this smooth muscle contraction can be affected by two different mechanisms. Okay? One's what's called electrical mechanical effects, and the other one is a pharmacomechanical effect. Okay? So you can break it up. Okay? One's electrical causing mechanical work. The other one is a medicine or some kind of ligand that binds to a receptor, which then causes mechanical work. Okay? It's just a complicated word, which I'm not sure why they did it that way, but that's what they named it as. Okay? Electromechanical or pharmacomechanical coupling. Which means that there could be diseases where you can have uncoupling. Okay? Uncoupling means that if you do get stimulation from, let's say, a pharmacological agent, you won't get the mechanical response. And that can happen if your receptors in that situation are downregulated, okay? Or your receptors are damaged, or your receptors are not working in the sense that they're denatured because they're a protein. So because due to changes in pH that are rapid. Those are pharmacomechanical kind of effects. Electromechanical effects, on the other hand, means that it has electrical voltages causing the effect. Okay? And that can be also changed by altering the actual electrical potential of the cell. Okay? Now, what this basic mechanism is doing is that eventually the secondary mechanism, his mechanical comportion, it doesn't matter what activates it, eventually the smooth muscle will actually begin to contract and cause vasoconstriction to take place. Okay? One of the things that's important for both of them, okay, is that if you don't have calcium, you don't get electrical, mechanical, or pharmacomechanical effects at all. Okay, so intracellular as well as extracellular, which we call the intravascular ionized calcium, is critical for vascular tone. Okay? I wish people would actually take that seriously, especially when we do our work. Okay? A lot of people forget this part. Okay? You get to a patient who has been resuscitated clinically with blood, and one of the bad things about resuscitating somebody with blood products is that most of our blood products have citrate in it. Okay? Not citric acid, but citrate. Okay? Citrate is what actually prevents the red blood cells from clotting. Okay? Because what it does is it chelates or takes the calcium that's in the plasma of that donated blood and holds onto it, so it basically prevents the clotting cascade from being activated. Well, you give like 4 units of blood to somebody, pretty much it's going to do the same thing to the person's intravascular calcium. So the intravascular ionized calcium is going to get basically depleted very rapidly. And then that person will show signs of hypotension, even though you've given 4 units of blood, and you're going like, what's going on? Why is the person not responding to therapy? I'm giving volume like I'm supposed to, and I know my preload's okay, but I got no blood pressure. Okay? In that situation, if you had a Swan-Ganz catheter, you would have a PA occlusion pressure of 15 to 20, and your blood pressure would be 80. And you'd be going like, what's going on? Stroke volume's adequate. Okay, so my problem at that point is not the heart, which is delivering adequate cardiac output. The problem is in the vascular tree. In this sense, it's because the calcium is not available to cause the smooth muscle to contract. You give that person 500 to a gram of calcium, all of a sudden your problem goes away. Such a simple fix. But you got to understand the mechanism, otherwise you won't even think of it. Okay? How many people have actually given somebody calcium in the unit and knew the actual mechanism and why they were doing it? Nobody gave calcium at all? Okay, everybody gave calcium, but they didn't know why. Okay, all right. That's fair enough. Okay, I like that. I like honesty. Okay? Okay? So what you're trying to do is you're trying to reinvigorate the smooth muscle with this nice calcium so it can contract and do its work. Okay? No calcium, no work. Okay? The good thing about the smooth muscle is as long as you got enough calcium on board, it will actually do prolonged periods of low energy cost work. Okay? So it's really not going to be the one that consumes the oxygen in your bloodstream. Okay? So it's not an oxygen hog. The other thing that electrical mechanically wise, if you stretch a substance, you cause electrical work to be created, believe it or not. Okay? Or you thump on something, okay? You will also cause electrical mechanical work to be generated, and the smooth muscle will contract in that area. Okay? So sometimes things can be activated by stretches as well. Now these are the actual mechanisms going at the cellular level. Okay? One's a voltage-gated channel, which is the electrical mechanical coupling. This is a voltage-gated calcium channel that we're talking about. Okay? So why is it important? Again, why is the concept that I'm giving you? Why am I bothering as a professor getting you down to the cellular level? Okay, why don't I just teach you, look, just memorize calcium is important in bloodstream, that's it. Because then you won't put together the other stuff that we're going to talk about, which is in pharmacology. If you give somebody a calcium channel blocker, what am I going to affect? I'm basically going to affect possibly these guys, these voltage-gated calcium channels in the periphery. So a drug like verapamil, which has 2 effects. It has an effect at the AV node, but it's a shotgun drug. It has many effects. It not only affects the AV node conduction velocity, but it also affects the peripheral vascular tree by causing the calcium channel to be inhibited. And that means what happens to smooth muscle contraction? It doesn't occur. So the person basically appears to vasodilate. Okay? And the person will get hypotensive in that situation. Okay? Another more selective drug, that you have available, which unfortunately we don't have that much here, but I wish we could, but it's so damn expensive, is cardine. Cardine is a calcium channel blocker, but it's more peripheral than central in the sense of it's affecting the heart. So it almost has no effect on the heart at all, but you can use it great as an antihypertensive. It's actually more effective than nitroprusside, and it's much more titratable without any of the cyanide toxicity effects of the actual nitroprusside. Okay? But invariably, the electromechanical as well as the pharmacomechanical coupling has to do with control of the calcium channel. So calcium channel is really what's controlling your smooth muscle. It's really one channel then we're looking at. Okay? The electrical mechanical coupling has to do with voltage gates and basically voltage around the cell. So if you depolarize the cell and it changes the milieu electrical activity, the calcium channel opens and then it causes the muscle to contract, which then causes vasoconstriction. If you look at the pharmacomechanical coupling at the cellular mechanism, you actually have to have an activator of the calcium channel that is a ligand-based kind of problem. In other words, you have to have a receptor, which means that you have to have a chemical that goes to the receptor and binds to get the secondary effect, which is a G-coupled protein that releases and allows the voltage gate to open and the calcium, the influx, and cause the smooth muscle contraction. Most of your alpha agents, in other words, most of your sympathomimetic drugs work by pharmacomechanical coupling. So epinephrine, norepinephrine, okay, Levophed, okay, phenylephrine. All those work by binding to these receptors at the surface, which we call alpha 1, and that causes the G-coupled effect of causing calcium to open and causes calcium to influx and cause contraction. So why do I teach you this? Well, there's several things. One is, all of you have heard of glucocorticoids. And somebody asked me this question, and I want to sort of answer it in class, too, because I think it's important. Cortisol most likely regulates the coupling that's taking place here. Okay? Cortisol is important to keep that coupled together. Okay? Your body creates at a constant level enough cortisol in your bloodstream to help keep the G-coupled proteins together. If my cortisol levels drop dramatically for some reason, let's say you're an athlete and you decide to abuse glucocorticoids or mineralocorticoids. Okay? You're giving yourself cortisol every day to boost your metabolism and boost your production of your muscle. But then you decide, you know what, I'm starting to have some complications and I want to stop. I'm starting to have rage issues, I'm getting really angry, and you know, I'm having sexual dysfunction from other problems. So I'm having issues, so he decides to stop. Okay? Well, the problem with stopping is that he suppresses the adrenal gland. Now his adrenal can't produce any more cortisol. Okay? So what happens is all of a sudden the blood vessels, the actual blood concentration of cortisol drops dramatically, and this becomes uncoupled. It no longer works. So even though I can release, if I'm running and I need to release norepinephrine at my blood vessels or vasoconstrict, guess what happens? Nothing. I get nothing. Okay? And all of a sudden I get hypotensive and I fall down and I'm dead. Okay? The same thing can happen to somebody in Addison's crisis. If you have somebody in Addison's crisis, they will be hypotensive in the recovery room with bradycardia. That's how you should know it's Addison's crisis. Hypotension, bradycardia. Because guess what? This is also a ligand that's also in the heart. So it's beta 1. So heart rate drops off because there's no, even though epinephrine is being secreted, there's just nothing to bind to. It binds to it, but it gets no G-coupled protein reaction and no calcium release. So you don't get the increase in heart rate, increase in contractility. So you get bradycardia, hypotension. Okay? And it's like magic. I've done this one time in clinical. I thought this person had Addison's disease, and everybody's like, oh, what are you doing? You're going, what? You're not giving ephedrine? I said, no, I'm giving steroids. And they're going like, you're crazy. I said, watch. 100, boom, blood pressure goes up to 120. Everything was stabilized. Heart rate came up nicely. It was beautiful. Okay, it's simply because the person had low levels of glucocorticoids. It's simply this uncoupling mechanism that's taking place. Okay, no cortisol, no coupling. Okay, does that make sense? Okay. Ultimately, the arterial basal tone is pretty significant. Okay, your blood, there's not enough blood volume in you for all your arterial tree to vasodilate at once and still maintain a nice systolic blood pressure. Okay, so your basal tone is very important for your arterial tone. Okay, there's actually also important things that actually introduce other factors besides the sympathetic nervous system, is that you also have what's called local effects. Okay, one of the things that's very difficult for me to try to explain to you, and because we don't really totally understand it completely in physiology, is that the arterioles sort of select who decides to be open. Not all arterioles are dilated at one time, okay? And no organ gets zero perfusion at any 1 minute, okay? But different portions of an organ get different degrees of perfusion per time sequence, okay? What the body sort of does is it sort of counts. The arterioles sort of have this count system, which is every time the pulsation hits it after so many times, then it opens, and then the other one closes next to it. So it keeps this tone kind of consistent throughout, but still maintains perfusion throughout that whole organ system without the organ cells behind it dying. That mechanism is thought to be two ways it's controlled. One is by the actual pulsatile beat, which is important, believe it or not. We know that to be true because when we put people on cardiopulmonary bypass, which is a continuous device that maintains only a non-pulsatile flow, you still get metabolic acidosis that takes place, even though the mean arterial pressure may be higher than what you started. Okay, so we know somehow the mechanism goes out of whack when you're not giving pulsatile flow. The other mechanism is local regulatory mechanisms, which means the cells behind it begin to communicate to the arteriole. If I develop greater levels of toxins in the cellular milieu that's behind that arteriole that's vasoconstricted, that arteriole is kind of stressed in the sense that, you know what, I got to let go a little bit to get some blood flow down here. So anytime that you get an increase in nutritional waste products, such as CO2, acidosis, okay, lactic acid, it will cause that arterial tone to try to vasodilate. Okay? The other thing that it also will sense, and is very sensitive, is oxygen levels. If oxygen becomes depleted, that cell will start screaming and start releasing even more stuff to cause that arterial tree to vasodilate. Okay? Even maybe to the point of things like metabolic base products that we don't completely understand. They may be also neurotransmitters to cause this effect. Okay? So things like increased levels of hydrogen ions, increased levels of CO2. Potassium is also one of those. Okay? And adenosine is another hormone that is released due to high levels of stress, will also cause vasodilation. Okay? So all those things are local effects that are not regulated at the central nervous system or anything like that. It's regulated in the peripheral in the actual cells themselves. Now, the arterial basal tone is also controlled by the endothelial cells. Okay? And the endothelial cells are really what produce the chemical that ultimately has significant effects on smooth muscle. And that chemical agent is nitric oxide. Okay? Nitric oxide is simply the most important vasodilator that your body uses. We mimic that action when we use nitroprusside or nitroglycerin. Okay? Nitroprusside and nitroglycerin both produce higher levels of nitric oxide. Okay? The downside to nitroprusside is it also produces cyanide as a side product, so you can get into cyanide toxicity with that drug. Okay? Versus nitrates tend to be more venodilators than they're arterial vasodilators. Nitroprusside tends to be more of an arterial vasodilator in comparison to a venodilator. Okay? And that should be reflected when you do some of the stuff that I asked you to do in some of your workbooks next semester. Your stretch activation will also lead to nitric oxide release. Okay? Agents that actually increase nitric oxide production will be things like acetylcholine, bradykinin, substance P. We also know that in certain conditions, under tremendous amounts of stress, nitric oxide levels will dramatically increase. Things like hypothermic shock. At the very end stage of hypothermic shock, the person will release massive amounts of nitric oxide into the bloodstream. And you actually will find people that are in hypothermic shock, usually nude. They actually rip off all their clothes right before they die. And I've seen that happen. I was wondering, what the heck's going on? When you read the literature, what happens in those people is they're so cold that all of a sudden the nitric oxide levels rise so fast that they vasodilate, and they feel like they're burning up in their skin, and they take off all their clothes to try to cool down. Although at that point, it's end stage, and most people die within a few minutes. So this is what controls your basal tone. Other chemical mediators that also change your arterial basal tone are inflammatory mediators. Okay? Things like your prostaglandins, histamine, bradykinin. You also have vasoconstrictors that are released by endothelial cells and platelet activation, such as thromboxanes and prostaglandins that are different than the vasodilating kind of prostaglandins. PGI2s and PGEs are different. They have different effects. I'm not going to go into all that specific because it's too much. But I want you to sort of know is that there's three different things that are really causing local metabolite control. Some of the nutritional byproducts. One is chemical mediators, such as inflammatory mediators, and the one is nitric oxide. Okay? Now, ultimately, what actually controls, on the sense of pharmacomechanical coupling, it really has to do with neural influences. Okay? Most of the pharmacomechanical coupling, can it be hormonal? Yes, partly it could be. Okay? But that ultimately is partly controlled by sympathetics. The release of norepinephrine and epinephrine is released from the adrenal medulla into your bloodstream, but that's regulated by the sympathetics. Okay? If you increase sympathetic discharge, you increase the release of these hormones into the bloodstream. So indirectly, they're neurally affected to a certain way. But the direct neural influences, which is the actual nerve endings directly coming to the smooth muscle at the arterial, is sympathetic only. There is no parasympathetic activation at all. Okay, so there is no parasympathetic vasodilation that's taking place. It's only sympathetic tone changing. If you lose sympathetic tone all of a sudden, then you cause massive vasodilation to take place. It has nothing to do with parasympathetics. Okay? Vasoconstriction can occur due to release of things like norepinephrine. The more selective alpha-1 agents, the more vasoconstriction can take place. Some alpha-1 vasoconstriction can be so potent as to cause a hypertensive crisis and have a reflex bradycardia take place. But it only takes place when you're causing somebody to have significant hypertension above their normal mean arterial pressure. Okay? Otherwise, things like if you give somebody neosynephrine, you don't have to worry about reflex bradycardia unless you make them hypertensive. So unless you're giving an overdose on the stuff, which is what you're trying not to do, usually don't see a deleterious effect. Okay? Most sympathomimetic or sympathetic drugs or endogenous sympathomimetic drugs have some degree of beta-1 and alpha-1 activity. Okay? There's variability in it. Okay? The earlier generation it is, the least alpha-1 effects it has. Okay, so you're looking at an agent like dopamine. Dopamine has a very weak alpha agent. It tends to be dopaminergic, beta, then alpha. Then you have norepinephrine, which has beta, but it has a lot of alpha. Okay, but if you have to say which one is stronger, epinephrine or norepinephrine, the answer tends to be mostly epinephrine. Has both a very potent beta-1 and also a very potent alpha-1. And the one in very high doses that's almost selectively pure alpha is phenylephrine and vasopressin. Okay, vasopressin is extremely alpha-1. Okay, but that's in very high doses. Okay, so your neural tone really maintains your basal tone higher than normal, which maintains your arterial blood pressure. Okay, so if you lose your spinal cord, is what we're telling you here, then you're going to cause hypotension. Okay, because where is the sympathetics located at? The sympathetics are between the thoracolumbar area. So anything that damages or anything that can affect your spinal cord at those areas is going to have significant deleterious effects in sympathetic tone. So a spinal, an epidural, can have very bad effects. Okay? If I also block sympathetic release, okay, either by preventing the receptors from receiving the actual receptor, so in other words, if I give a sympatholytic drug, which inhibits the sympathetics from binding to it, then it has a significant hypotension effect. Now, does nitroprusside do that? The answer is no. The nitroprusside has nothing to do with the effects at the level of the receptor. It affects the actual tone from inside the cell. That's why it's so potent. You can have somebody trying to vasoconstrict intently, but their nitric oxide levels are so high in that situation that the person vasodilates. So sometimes the local effects can actually be more significant than even a very intense sympathetic discharge. But that's unusual most of the time. Circulating catecholamines can also take place. The circulating catecholamines are sympathetic discharge, which then goes to the adrenal medulla, which is the inner portion, okay, which then releases in the bloodstream norepinephrine, epinephrine that have the effect. Okay? And the beauty of the adrenal system is that it showers the whole blood vessel system very rapidly. Okay? The downside to it is it's non-selective. It can't tell which specific organ to shut down. So what it tends to do, unfortunately for us, is that it kills the kidneys and will kill the GI tract very fast, unless you reverse the effect. One of the things that we know is if we can shut down the pain response in people, the sympathetic discharge never gets activated, and people seem to have less organ system damage from high levels of stress. So when we put an epidural beforehand, and then we dose it and have a person comfortable intraoperatively, even though they're under general anesthesia, we're actually going to have some possible good beneficial effects. Okay? The downside to it is that if you also give somebody a spinal or an epidural that is under massive amount of hemorrhaging, you have no vasal tone to increase to try to maintain your blood pressure. That's the downside to it. You have to resuscitate that person aggressively, more so than if you had some degree of vasal tone. So it's always a two-edged sword. Alpha-1s are usually located in your peripheral vasculature. It's mostly the one that causes vasoconstriction. What it does is it shunts blood more to the skeletal muscle. If you cause alpha-1 vasoconstriction, you will shunt blood to the blood vessels of the skeletal muscle. It will shunt the blood away from the organs. Beta-1, on the other hand, is located mostly in your heart. It increases your heart rate, so it increases velocity, and it also increases contractility, because sympathetics are also located inside the ventricles, as well as in the atrium. So it increases atrial kick, and as well as ventricular contractility. As for your beta-2 receptors are located mostly in where? In the lungs. And beta-2 is really important, and it's mostly activated by epinephrine. It causes bronchodilation. Where is beta-2 also found at? Kidneys, partly, yes, but what's more important than that? If you had to run, what would you want your blood flow to go? Skeletal muscle. So skeletal muscle also has beta-2. Okay? Epinephrine is beta-2 receptor activation. It's causes skeletal muscle vessels to dilate, as well as coronary muscles to dilate, but also causes bronchodilation to take place. So epinephrine is one of those great drugs that does everything that you want in the sense of running away, and it also helps open up your lungs. Okay? It also has pretty strong alpha-1, which causes intense vasoconstriction of organ systems, and that's where its downfall is. Okay? Most of the time, you don't really care about skeletal muscle so much. You want to keep your organ systems alive, and that's the downside of epinephrine, is it can be such a potent alpha-1 that you can lose some major organ systems. Vasopressin, usually something that we don't talk about too much, because unless you're using code qualities, if you're expecting the patient's ADH to be supportive of your blood pressure, well, that accounts for anywhere between 0 to 5% of your overall basal tone. So it's not very much. Okay? Your renin-angiotensin system is the other 20%, and the 75 to 80% is most of your sympathetics. So when you're looking at the antidiuretic hormone, okay, what actually eventually leads to very intense levels of vasoconstriction, that's when you get into massive releases of ADH. Things that will actually promote that will be increased osmolarity, stress, trauma, exercise, nausea, decreased volume, which is a mechanical receptor in the atrium and parotid, all stimulate antidiuretic hormone release from the posterior pituitary. As for your inhibitors of it, if you have decreased osmolarity, things like estrogen, progesterone, angiotensin II levels that are elevated at very high levels will also induce decreases in ADH production. The other thing that alcohol does too is it suppresses ADH release, which makes you even more dehydrated. Alcohol, first of all, is an osmotic diuretic, and then in addition to that is an ADH inhibitor, which then the person begins to lose their volume much more rapidly. If you want to not ever have a hangover after you've been drinking all night, right before you go to sleep, take about a gallon of water and drink it all. And usually you won't be, you would be puking maybe, but at least you won't be dehydrated the next morning. You won't be feeling sick. Okay. The dehydration causes a significant drop in CSF volume, and that's why you have the splitting headache the next morning and you feel sicker than a dog. You basically are mimicking a posterior puncture headache. So if you've had a hangover, you know what a person feels like with a spinal headache. Okay? So most of us have experienced that one time in our life, and usually most of us learn from the first time not to do it again. Some of us don't, but some of us do. Anyways, this is the next mechanism that controls your blood pressure besides the sympathetics, and that's your renin-angiotensin system. You need to know this by heart. This is going to come over and over again to you. The orange box in here, which is renin-angiotensin release. The renin is the first enzyme that's being released. This enzyme breaks down angiotensinogen into angiotensin 1. What actually activates the release of renin is sympathetic discharge, as well as decreased levels of blood flow to the kidneys. The other thing that also stimulates it is nitric oxide, the macular densus, cyclic AMP, diuretics, epinephrine, norepinephrine, certain diurnal rhythms, and the person standing up will also increase the levels of renin release. When renin is released, it causes the conversion of this factor of angiotensinogen into angiotensin 1. Angiotensin 1 gets into your venous system where nothing really happens. It does not cause vasoconstriction of your blood vessels on your vein side. So until it gets into the lungs, and then it gets converted by what's called angiotensin converting enzyme into angiotensin II, which then angiotensin II is a very potent arterial vasoconstrictor. Okay, so if somebody asks you, where's angiotensin working at? It's working at the arterial side mostly. Okay, it causes significant arterial vasoconstriction, and it also stimulates the release from the adrenal cortex of aldosterone. Okay? Aldosterone comes back to the kidney and increases the sodium reuptake, which then increases the water reuptake, so the person becomes more volume re-expanded. Okay? Things that also will inhibit renin release will be this back variable with negative feedback of angiotensin II. Aldosterone, which is also increasing, could also be a negative inhibitor. When you put somebody laying them down or later part of the day, renin-angiotensin system begins to shut down. Okay? So you tend to be lower in your blood pressure by the end of the day than in the beginning of the day. Okay? At least by this mechanism. Things that also increase aldosterone release besides angiotensin II will be increasing levels of adrenocorticotropic hormone, which kind of makes sense. If you say adrenal cortex, okay, that's what the ACTH is for. The cortex is the aldosterone. Okay, remember, the outside is what produces aldosterone and the mineralocorticoids. Hyperkalemia and hyponatremia will also induce an increased levels of aldosterone levels. Okay. This is sort of what you expected to know for your exams, especially when you get to boards as well. What happens with certain kinds of receptors. You have to sort of memorize this. You have to know this. What I do is I do it in a box form, or if you're visual, like I am, okay, What I draw is I stick figure, and then I just put my actual receptors where I think they belong. Okay? Beta 1 would be the heart, beta 2 in the lungs, skeletal muscle. Okay? Alpha 1 is in your peripheral vasculature. Okay, so that's arterioles and veins. It constricts them. If you're looking at glands, it decreases secretions, which kind of makes sense. You don't need to be your mouth wet when you're trying to run. You want your mouth dry so you don't have sputum coming out of your mouth as you're running. Okay, so drying you up is a good thing. Okay, you're not drowning in your own saliva. Okay, so that's kind of good. The bad thing is if you're, just remember what it was like to be in an interview. All you had dry mouth, and that's what it's from. It's from the epinephrine surge. Okay, you also have your eyes. You look at your eyes will become dilated. Okay, you'll have big eyes. Okay, the person who's in fear usually has very, very big eyes. That's how you can actually pick up somebody who's doing something bad. Okay, usually they have an epinephrine surge. They can't hide that. You look at their eyes are dilated inappropriately. Okay, if you see somebody's eyes closed down, usually it means that they're very calm. Okay, they're mostly in a stage that they're trying to relax. Okay, or if you could actually have somebody that's a really good murderer and he just doesn't care. He's calm. He doesn't get the epinephrine surge. Okay, intestine, you have decreased motility, which is good. Alpha 2 is a feedback mechanism that sort of prevents alpha 1 to become too involved. If you have too long of alpha 1, you will kill the organ systems. So alpha 2 is basically a negative feedback mechanism to suppress the system of release of any more norepinephrine. So things like clonidine. Clonidine is a alpha 2 receptor agonist. Okay? And it causes the action of inhibiting the release of a norepinephrine at the presynaptic terminal, which then drops the blood pressure. Okay? It also causes alpha 2 receptor activation on the beta islet cells of the pancreas. It decreases secretion of it, okay? Which drives your sugar levels up. That's not good. Okay? Sugar is deleterious to your brain. It gets too high levels. The importance of why the sugar levels go up under stress is because you need higher sugar levels to try to think quickly. So your body tries to do that for you. The downside to it is that if you get into a shock state, there's too much sugar around and your brain keeps trying to work despite not having adequate oxygen, and then you have more sense of damage that occurs in that situation. Beta 1 receptor is increasing heart rate, contractility, conduction velocity, as well as automaticity. And for the kidney, it increases renin secretion. Beta 2, it causes bronchodilation. If the woman is pregnant, beta 2 activation will cause relaxation, and the arterioles will also cause dilation, which in this case is going to the skin and as well as the skeletal muscle. So beta 2 is actually shunting blood to skeletal muscle and to skin, which is good because why is it good for the skin? Dissipate heat. Okay? What this is trying to do is trying to get you to run. Okay? Beta 2 activation will cause the skin to get more perfusion, dissipate more heat loss, and be more effective in your system. You won't core burn up. Okay, as for your control, your venous tone is controlled to a certain degree by your sympathetics again, okay, but not as intensely as the arterial tree is. Okay, if you lose sympathetic tone, you'll still maintain a certain degree of venous tone. Okay, not as you would in arterial. The arterial system would vasodilate very rapidly on you. Okay. Veins, as a whole, have very little basal tone, so veins are subsequently normally in a dilated state. So if you lose sympathetic tone, are you really going to lose that much in venous tone? The answer is really not that much. Okay? Vasodilator metabolites also have very little effect because what are all the metabolites going through there? They're bad stuff. I mean, that's what's returning back to the heart, so it eventually gets going to the lungs, and then eventually gets going into the kidneys. Because of the thin walls, most veins are more susceptible to physical influences. So external compression is actually much more likely on the venous system than on the arterial system. Okay, so this is the differences in your reflexes versus local influences. The arterioles are very much affected by sympathetic constrictor tone. So are the veins, but not as much. As your local influences, basal tone is very important for arterioles, as well as vasodilator metabolites. As for veins, it's mostly passively distended, and external compression has more effects. The actual basal tone is very small, and vasodilator metabolites almost have no effect at all. If you're looking at other specific organ systems like the coronary blood flow, that local metabolite control outweighs vasoconstrictive effects, especially things like adenosine can have significant coronary vasodilating effects. Nitric oxide, nitroglycerin also works by affecting the nitric oxide, which then causes the person to vasodilate. Okay? If you look at the splanchnic system, the celiac plexus, superior mesenteric plexus, and the inferior mesenteric plexus usually have intense vasoconstriction under sympathetic discharge. When you do a spinal and you knock these guys out, that's when you get significant hypotension. So right around a T6, which you knock out the celiac plexus, that's when all of a sudden the person becomes severely hypotensive. Okay? The heart rate will increase in that sense because you still have the cardiac accelerator fibers, which are up in T1 to T4, but you will have hypotension with tachycardia. Okay? Renal blood flow can also be significantly inhibited by sympathetic overstimulation. The cardiac output that actually is going to the kidney is very high, so it accounts for about 20% of the cardiac output. So that's a lot, okay? And the reason it's so high is because it has to filter so much. So when we talk about this next semester, when we talk about the rest of the renal section, we'll go into that in a lot more detail. Cutaneous blood flow, sometimes you have different situations. It is considered the largest organ in the body. If somebody ever asks you which is the largest organ in the body, it's the skin. Okay, a lot of people don't remember that. Okay, they'll think it's the liver. It's not. It's the skin. It's considered an organ. Okay, you can actually shift a significant amount of volume from central venous compartment to the skin, and you can get hypotensive with it as well. So it's a thing to consider. Pulmonary blood flow is mostly regulated by local metabolite controls via what's called HPV mechanism. The book says that there's minimal. I tend to disagree with the book in that respect. HPV is still ultimately regulated to a certain degree by the central nervous system. The reason I tell you that is because a patient who is in brain death will develop pulmonary edema very rapidly. The other thing that you'll see somebody who develops brain death is you'll get a big change in VQ mismatch, and you will have to have increasing FiO2 levels to maintain that person's organs to survive. So HPV is regulated to a certain degree by the central nervous system. Overall, if you have an intact central nervous system, is something can you notice? The answer is no. But if you lose the central nervous system, then it does start to affect the lungs. Okay. What this picture is showing you is how perfusion takes place between the right and left coronary arteries. I want you to pay particular attention to that the left coronary blood flow, which is your LAD, left main circumflex artery, is limited during systole. Okay, it's almost zero. Okay, versus the right side perfuses, which is the RCA, perfuses through the whole cardiac cycle. And the answer is why? And the answer simply is that the pressure inside here, this is the diastolic pressure, that's what's maintaining your perfusion. But look what happens when ventricle begins to contract. The pressure of these two are equal. So what's the delta P then? ADP minus ventricular and ventricular pressures. Which in this pressure here, this ventricular pressure and this aortic pressure is equal to each other. So because of that, you get no delta P. And that's why perfusion stops during systole for the left ventricle. So the left ventricle does not get perfused during a systole. Okay, only the right side of the heart gets perfused to the whole cardiac cycle. Somebody asked that in the boards about 2 years ago, and some people didn't know that, and our students mostly got it because of this discussion. Okay, so that's good. But diastolic pressure is maintained at its highest levels for the left ventricle, and that's where perfusion takes place optimally for the left ventricle. When you put an intra-aortic balloon pump in somebody, what you're waiting for is for it to bump up here, and you increase the actual amount of diastolic pressure, which then that would cause this pressure to increase like that. And that would improve your perfusion to your coronaries. If you were to increase it here, what would happen? Right, you would increase the afterload and you would stress the heart even more. So intra-aortic balloon pumps are not for systolic pressures. It's only for diastolic pressures. Okay? All right, and the last thing is when your body regulates blood pressure, you always have to keep it separate. One is brain, lung, and then keep the rest of the organ system separate from it. Okay? The brain is going to do very much different things than the peripheral vasculature. Okay? The brain is a hog of oxygen. Just remember that always. Okay? It's always going to keep itself alive at all costs. It doesn't care about anybody else. It's just selfish in that respect. It wants to keep itself alive under all circumstances. Okay? So if I'm hypotensive peripherally, okay, it's going to try to do everything it can to vasoconstrict you peripherally to try to shunt blood back to my brain. Okay? So sometimes you'll see that the person is vasoconstricted intensely peripherally, but their brain is actually intensely vasodilated. Okay, it does the reverse of what the peripheral system is doing. Okay? So if you see somebody with hypertension, you will see that the person's blood vessels are actually dilating to increase perfusion through it. Okay? If on the other hand you have a situation where you have too much blood flow going to the brain, it will then immediately tell the rest of the body to vasodilate to try to shunt the blood away from the brain. Okay, so it's always doing the opposite. Okay? Now, the same thing applies for CO2. CO2 is one of those things that, as a student, most of us see some things in clinical and they don't really understand why they see it. When you're doing a laparoscopic procedure, this is a perfect example of CO2-induced hypertension. Okay? When you put somebody and put a trocar in their belly and you insufflate CO2 in their belly, you will notice that your end tidal CO2 will rise. That means that person is actually absorbing the CO2 into their bloodstream and it's going to the lungs. Okay? The CO2 acts like a norepinephrine or a phenylephrine drip. It will intensely vasoconstrict the periphery. So even though you put a person in reverse Trendelenburg with their feet down and their head up, you still will maintain blood pressure. It's counterintuitive. And most students will go like, how come the blood pressure is okay when we've got the guy like, you know, he's almost standing on his toes. And we got him under general anesthesia. And I seem like I have to crank up my anesthetic even more to keep the blood pressure from zooming upwards. Okay? I had one case where they called me in and the CO2 was 62. And the person says, well, I can't ventilate this guy off. And I said, you're not going to do it. And he says, well, why? I said, well, the trocar is not in the right place. And he goes, I tell the surgeon, hey, you know, you got the trocar is not in the right place. The surgeon looks at me and says, nah, the trocar is fine. So I said, okay. So I put my hand on the person's chest, and guess what I could feel? Crepitus. It was like Rice Krispie time. And I said, no, man, you got crepitus, and you got CO2 inside the fat tissue. That's why he's absorbing so much. The person was so obese that the trocar couldn't get deep enough and be all the way into the peritoneum. Okay, so he had to change it out, put a longer trocar, got that in, and all of a sudden their CO2 levels went right back down. Blood pressure came back down. Everything got better. Okay, again, got to be careful. Watch what everybody's doing. Try to understand what's taking place. If you see a high level of CO2 like that, you should be jumping it up and down because it could be malignant hypothermia. Okay, but if it's usually from a laparoscopic procedure, there's something wrong with the trocar. Okay, especially after they insert it, that's when everything goes to heck. Now, what do you think happens to this person complaining afterwards? What's their biggest complaint after this kind of procedure? Complaint of headaches. They have severe complaints of headaches after these procedures. And why is that? What happens to your blood vessel when your CO2 elevates? What happens to blood flow? It goes up in the brain. So all of a sudden your brain gets tremendous amounts of volume, the brain gets a little edematous, and it gets a headache. Okay? So it always does the opposite. So when you look at this curve, this is what the brain's doing. That's not what the body's doing. Okay? If you see an elevation in CO2 like this, the brain increases perfusion. Okay? You see blood flow is going up. Okay, CO2 is going up. But the body is vasoconstricting to do that. Okay? So you see hypertension in these people. All right.